Welcome to This Explainer, where we're going to completely transform your approach to intraocular inflammation. As an educator and program director, my ultimate goal is to guide you through passing your OCAPs and your boards with absolute confidence. Look, if you're preparing for exams right now, or even just trying to keep your head above water in a busy clinic, it is so incredibly easy to fall into the trap of short-term textbook memorization. But today, we're going to build true, long-term clinical mastery. I'm not just going to ask you to blindly memorize facts. We are going to dig into the why behind the pathology. I want to help you see uveitis for what it really is, a biological process of pattern recognition. So, to build that bulletproof mental model for the boards and for your patients, we're going to cover uveal anatomy and diagnostic profiling, anterior uveitis and granulomatous disease, intermediate and posterior uveitis, panuveitis and endophthalmitis, and finally, scleritis and masquerade syndromes. All right, let's jump right into Section 1, Uveal Anatomy and Diagnostic Profiling, Building the Framework. We have to start with foundational anatomy, because you simply cannot diagnose what you don't fundamentally understand.
Take a look at this cross-section of the eye. I want you to think of the eye as being composed of three distinct layers, or tunics. The outer fibrous layer is your tough sclera and cornea. The innermost layer is the neurosensory retina, and the uvea, which is made up of the iris, the ciliary body, and the choroid, is that highly vascular, deeply pigmented middle tunic sandwiched right between them. So you might be wondering, why is the uvea such a massive target for systemic disease? Well, it all comes down to physiology. The choroid has an incredibly high rate of blood flow, and its fenestrated capillaries act almost like a giant filter, basically allowing circulating immune complexes and systemic infectious agents to readily deposit and cause profound intraocular inflammation.
Because the uvea is so deeply connected to the rest of the body, before you go and order a massive, expensive panel of labs, you must follow this 5-step clinical algorithm. First, profile the patient systemically. Second, mesh that profile with known disease patterns. Third, build your differential. Fourth, order targeted studies. And finally, initiate treatment. Let's actually apply this. Say you have a 40-year-old Middle Eastern woman presenting with tinnitus and panuveitis. That triggers a very specific profile. You should immediately be thinking of Vogt-Koyanagi-Harada syndrome or Behçet's disease. Now compare that to a 20-year-old male with lower back pain and acute anterior uveitis, which strongly points toward an HLA-B27 spondyloarthropathy. See the difference? Profiling literally guides your entire diagnostic workup.
Moving right along to Section 2, Anterior Uveitis and Granulomatous Disease, the front of the eye. Let's start with the most common site of uveitis you're going to encounter in clinic.
Look at the difference in these two presentations of a red eye. This is a classic board trap. Notice how the surface conjunctivitis on the left is uniform across the entire globe, but the anterior uveitis on the right exhibits a classic ciliary flush. The redness is most intense right at the limbus. You're actually looking at the congestion of the deep episcleral vessels directly overlying the inflamed ciliary body. To confirm this clinically, just use a cotton swab. If the vessels move easily with the conjunctivita, the inflammation is superficial. But if they stay fixed, or if they fail to blanch when you apply topical phenylephrine, you are dealing with deeper episcleral injection.
Now check out this conical slit beam. Understanding the pathophysiology right here is absolutely crucial. Normal aqueous humor is optically clear, and that's because of the tight junctions in the non-pigmented ciliary epithelium. The breakdown of this blood-aqueous barrier allows leukocytes, those tiny floating cells, and protein, which is that hazy flare, to leak into the anterior chamber. The presence of cells tells you there is active inflammation happening right now, while flare tells you there is profound vascular permeability.
Okay, let's pause for a second. Here is a classic OCAP board question for you. Time for some active recall. How do we actually define granulomatous uveitis clinically at the slit lamp versus histologically? Take a second to really think about it before we move on.
All right, so here is the key. Clinically, granulomatous refers entirely to this specific slit lamp appearance. You're looking at the endothelial surface of the cornea. Those large, grayish, waxy inflammatory deposits, those are mutton fat keratotic precipitates, or KPs. Pathophysiologically, these are composed of macrophages and epithelioid cells clustering together, which is what gives them that thick, greasy look. Totally distinct from the fine punctate KPs of non-granulomatous disease that are just made of lymphocytes. In the clinic and on the boards, this macroscopic appearance dictates your granulomatous differential, regardless of whether you have histologic confirmation of giant cells.
You absolutely have to commit this differential to memory. To
To structure this efficiently for the boards, divide them into infectious and non-infectious systemic causes. Your infectious granulomatous etiologies include syphilis, TB, Lyme, herpes simplex virus, and toxoplasmosis. Your key non-infectious systemic etiologies are sarcoidosis and VKH. Any of these systemic masqueraders can present as an isolated granulomatous anterior uveitis, which makes a rigorous review of systems your single best diagnostic tool.
Stepping further back into the eye, we hit Section 3, intermediate and posterior uveitis, vitreous, and retina. Let's explore the inflammatory processes happening much deeper in the globe.
Listen, do not fall into this common semantic board trap. Do not confuse intermediate uveitis and pars planitis. Clinically, these patients typically present with floaters and blurry vision, but crucially, they lack the severe pain, redness, and photophobia we just saw in anterior uveitis. The term intermediate uveitis is used when this inflammation is tied to an identifiable systemic disease like multiple sclerosis, Lyme, or sarcoidosis. Pars planitis, on the other hand, is the exact same anatomical presentation at the vitreous base, but the condition is completely idiopathic.
Imagine you're looking into the inferior vitreous cavity through an indirect ophthalmoscope. Those clumps of inflammatory cells and detritus suspended in the vitreous, those are classic snowballs. Over time, gravity pulls these cells inferiorly. When they pool along the pars plana in broad, dense swaths, they create an exudative plaque called snowbanking. And remember, you'll often need to utilize scleral depression on your physical exam to actually visualize the snowbanking properly.
Time for a little more retrieval practice. This is a super classic board presentation. A patient presents with a dense vitritis overlying a retinochoroiditis. Think about your infectious posterior uveitis causes, think about their systemic vectors, and ask yourself, what parasite with felines as its definitive host is responsible here? Lock in your answer.
You got it, it's Toxoplasma gondii. And looking at this, you can beautifully see why it's clinically described as a headlight in the fog. Pathophysiologically, toxoplasmosis causes a primary retinitis. That's the bright, active yellow-white lesion or the headlight. The intense immune response then triggers a massive secondary vitritis, which creates the hazy fog right over it. For board prep, make sure you know that vision-threatening lesions are typically managed with classic triple therapy, pyrimethamine, sulfadiazine, and folinic acid.
Shifting gears, let's dive into Section 4, panuveitis and endophthalmitis, total ocular involvement. These conditions represent a severe, diffuse disease burden that inflames literally every compartment of the eye simultaneously.
To qualify as panuveitis, the anterior chamber, the vitreous, and the retina or choroid must all be equally inflamed. Notice how our great systemic mimickers, syphilis, TB, sarcoid, and Lyme, appear here yet again on the slide. Prognostically, this is vital. Eyes with panuveitis are at an incredibly high risk for phthisis bulbi, which is a shrunken, non-functional eye, if they aren't aggressively managed with immunomodulatory therapy. The eye is simply the canary in the coal mine for profound systemic disease. Here's a massive clinical pearl for you. Do not confuse panuveitis with endophthalmitis. Endophthalmitis specifically refers to an active bacterial or fungal infection. Clinically, these patients are going to present with a thick hypopyon in the anterior chamber, severe pain, and a precipitous drop in vision, usually following intraocular surgery or trauma. The acute management algorithm here requires an immediate vitreous tap and injection of broad-spectrum intravitreal antibiotics, typically vancomycin and septizidine.
And finally, we arrive at Section 5, scleritis and masquerade syndromes, the clinical curveballs. These conditions might masquerade as standard uveitis or standard red eyes, but they require an entirely different diagnostic paradigm. Scleritis is a painful, infiltrative edema of the sclera. Posterior scleritis is especially tricky because the inflammation is hidden entirely behind the eye, so your history taking here is literally everything. The patient will describe pain radiating to the brow, pain that is severe enough to awaken them from a dead sleep, and pain aggravated by eye movements. Why does it hurt to look around? Pathophysiologically, it's because the extraocular muscles insert directly into that actively inflamed scleral tissue. Now, look closely at this B-scan ultrasound because orientation is everything. The bright, hyperreflective arc you see? That's the sclera. Notice the anechoic, meaning black, space directly behind it. That is fluid in subtenon space. If you follow that fluid tracking down to where it meets the perpendicular acoustic shadow of the optic nerve, that intersection forms your classic T sign, which instantly confirms the diagnosis of posterior scleritis.
All right, one last high-yield board trap for you. Profile this patient. An adult in their 60s presents with vitritis, creamy yellow subretinal infiltrates, which are often beautifully described as leopard spots on fluorescein angiography, and crucially, recent personality changes mimicking a CNS infection. So what is the diagnosis?
Boom, you nailed it. Primary vitreoretinal lymphoma. This is the ultimate masquerade syndrome, faking a posterior uveitis while hiding a systemic malignancy. Because 60 to 80% of these patients will eventually develop primary central nervous system lymphoma, the mortality risk is extremely high. You absolutely must confirm the diagnosis by finding malignant big blue cells on a vitreous biopsy and co-manage this with neuro-oncology immediately.
Let's do a rapid-fire review to tie this entire framework together. Remember, granulomatous means large, mutton fat KPs made of macrophages. Snowballs point to intermediate uveitis. A positive T sign on a B scan means posterior scleritis. And always profile your patients systemically. Ultimately, true clinical mastery comes from realizing that diseases aren't random flashcards. They are biological patterns of anatomy, demographics, and systemic relationships. If you build this framework, you will never be lost in a diagnostic workup again. So what patterns will you recognize in your clinic tomorrow? Keep reviewing, keep connecting the dots, and we'll see you on the next explainer.